meeting of the IJB here on the 22nd of February. We have quite a full agenda, as you will see. So I'm going to make a start. I'm going to ask, I don't know, is it Arlene? Are you taking us through this morning, Arlene?
I am, yes.
Thank you. We're so pleased to have you.
Thank you.
Oh, that's right. Okay. Sorry, I thought that Arlene wasn't here, but there's two Arlenes. I'll put my mic off now. Sorry.
Okay, Arlene.
Yeah, thank you. Can I just remind everyone that the meeting is being recorded and will be placed on the Council and Partnership websites for public viewing. And I'll now take a roll call for the minute. Pat Kilpatrick.
Here.
Councillor Lynn.
Present.
Councillor Toland.
Sorry, I'm here. My internet's a wee bit funny, so I'm dipping in and out. Sorry.
Okay,
I'm here.
Thank you. Councillor McHugh.
Here.
Annie Buchanan.
Present.
Sam Riddle.
Present.
Diane McCulloch.
I'm here, Annie, thank you.
Vicky Irons.
Yeah, present.
Dave Berry.
Present, Arlene.
David Wilson.
Present, Arlene, thanks.
Sarah Dickey.
Present.
James Cotton. Raymond Marshall.
Yep, here, thanks.
Jim McFarlane.
Yeah, morning, Arlene, I'm here.
Thanks. Christina Cooper.
Hello, sorry, yes, I'm here.
Thanks. Martin Sloan.
Present.
Emma Fletcher.
Present until 11:30, thank you.
And David Shaw. Chair, that concludes the roll call.
Thank you. Thank you so much, Arlene. Okay, do you want to take us through the declaration of interest?
Yep. So item 2 is declaration of interest. Are there any declarations? No. Okay. Item 3 is the minute of the meeting held on the 14th of December 2022, which is submitted for approval.
Okay, are there any questions or points or clarifications on the minute that anybody wishes to submit? Anything you think needs to be amended, speak now. If not, can I have somebody to propose and somebody to second? So I've got Sam proposing, somebody to second this minute, please.
Second it.
Thanks, Dorothy. Proposed and seconded, thank you. Okay, Arlene.
Okay, so item 3B is the action tracker, which is attached for noting and updating accordingly.
Again, is there anything on the action tracker? I see under the community custody unit, we were asking for a member of the Scottish Prison Service to maybe come and just give us a bit more detail around how the unit and how it functions and the benefits of it. And what they've learned about it since it opened. And we set a suitable date in the future. We're now in nearly the end of February, and we've discussed this a few times, I think. So I just wonder if we could maybe make that request again, perhaps for the next meeting, if everybody's okay with that. If somebody could be encouraged to come along. It doesn't need to be the most senior person in the unit or in the Scottish Prison Service. It's just somebody who can explain how it fits in and how it benefits people. Dorothy, you've got your hand up. You're on mute, Dorothy.
Beg your pardon. Beg your
Thank
pardon.
you. That's okay.
Items 10 and 11 on the last page of the action tracker don't appear to have any update or colour coding. I do like my colour coding.
What do we think, Debbie, Vicky, on this?
Chair, sorry, can I just come in?
Yeah,
Can I just come in on that? Yeah, that's an error on our part. That's two that we've forgotten to kind of update when we've updated the rest. So apologies for that. I don't know if so in terms of item 10, we did have kind of Roger Many was going to kind of take us through a session a couple of weeks ago that originally we had planned for 2 hours. Had to drop it down to an hour for a clash, and then because there was kind of a number of apologies, we'd consider we reschedule that, so that would kind of touch on, you know, the original 2 hour session would have kind of picked up a bit about integration scheme on that.
I think he's got a date now, haven't we? We've got another date.
Another date in. Okay, I didn't clock that was that was the case. So we'll pick it up at that point as well. Okay. And I don't know, Diane, about kind of item 11. I know the Constitution House side of things has been discussed a number of times, but
yeah. So first of all, Pat, in relation to the Scottish Prison, I'm happy to take that as an action, contact them and ask them if they're prepared to come along. I think at the time that we were having the Scottish Prison to come, we'd actually asked them to come prior to the unit being open to have a conversation, and that was in relation to a concern that this might impact on our health services in terms of the support that needed to be offered. I think, and at the time we'd asked them, they were literally in the process of setting up, so they weren't able to attend a specific meeting, but we did have a report. I think what's since happened is the service is now up and running and fully operational with no particular issues. So I guess it's whether or not we're asking them to come to provide us with a general update and an explanation of what is going on in the service, as opposed to our initial concern, which was about the impact of the service on our services. So I'm sure we can ask them to just come along and give us a bit of an update. We can do that as a verbal or a presentation, but I guess it's the relevance of it still to the IJB and how they might want actually to do that, as whether it's as an agenda item or if we ask them, for example, just to do a briefing. So I guess it's about the continued relevance of the action and how we might want to take that forward, but happy to do that.
I think that's really helpful, Diane. Thank you for offering to do that. I think at some point as well, I don't know what my colleagues think, but it might be good for people to get an opportunity. I know they'll be very busy getting it all organised, but maybe an opportunity at some point just to get a look round and an opportunity just to see what the facility offers, because I think it's the first in Scotland, isn't it?
Yes, it was at the time, yes.
Yeah, and I think it's a great thing for women that are in custodial care. So I see Dorothy nodding her head. I think she's going to be first on the list to go and...
No, I've been in it.
Oh, you've been?
Yeah, you must go and see it. It's fantastic. That's
brilliant. Thanks, Dorothy. That's great. That's great to know. So maybe we could follow that up subsequently, Diane, but thank you for that. So, Constitution House.
If we come to Constitution House, so I think I've explained a few times. Sorry, I hadn't realised that the update wasn't on it, so I take personal responsibility for that. I've explained a few times that currently in Constitution House there are 70 members of staff. Included within that is a Home Office licence to be able to deliver and administer Buvidal 5 days a week. We have a range of staff, including psychological therapists. We've got a pharmacy in the building in order to store our drug system. We need to be able to deliver and write up prescriptions in terms of ongoing prescriptions, because we do the repeat prescriptions, etc. So there's quite a lot of clinical work that needs to be addressed before we can really think about the model that we're taking forward, and we need that sense of security. We weren't able to do that in terms of third sector. We've looked at a number of properties and we've not been able to identify anything that would be a natural kind of step down. So what we've done over the last little while is look to see how do we deliver the clinical aspect of this work, see if we can find a site that allows us to do things like progress towards Home Office licence and deliver a number of those services. And we're currently looking at the Wallace Town Centre with the GP practice moving out of there. We already deliver some services from that building. We deliver one of our drop-in access services from that building, and we're pulling together. So we've got a group actually coming together over the next, well, I've got a group looking specifically at what do we need for Wallace Town to take that forward, what work needs to be done to make it done, and how do we start to do things like looking at transferring our Home Office licence. So that's our step at this point. We think we hopefully have the Wallace Town Centre as a place to go to. I'm talking as if we have it, and the hope that just means it'll happen, but we're doing the work behind the scenes to make sure that all the kind of more kind of work that needs to be done will be done. And then at that stage, we'll then know what we're looking at in terms of the rest of the staff, in terms of being able to think about that from working in different community settings. So need to get the clinical bit sorted. I think we've got a plan. We're just working through the technical aspects of that. As soon as we know that that's absolutely been sorted and confirmed, we'll come back.
Okay, that's great. Thank you so much for that, Diane. So we can just add that into that, what Diane has just given us, we could just add that into a revised version of this action tracker, Dave. Are there any other points? I see Martin's got his hand up and Ken, oh, sorry, Ken. And Ken's got his hand up. I'll bring in Martin first because he's had his hand up for a wee while. Martin?
You know, my hand's now down. It was it, Dorothy covered the same point I was going to cover.
Thank you. Thank you, Martin. Ken, you're on.
Yeah, this is the shortest action tracker I've seen for a long time, which is good. Lots of green in there. So given that it's so short, we've already agreed one future action. I wonder if we could also have whoever the manager is of the new Community Wellbeing Centre along as soon as really to discuss, you know, the way forward for that service and tell us more about it. That would be good, I think.
Okay, that's great. Thank you.
We can maybe pick, sorry, Chair, we can maybe pick that up when we come on to the update later on, because I think we've got a position in terms of when we can expect there almost to be a soft launch. I think it would be good if we could tie that in with one of the IJBs around that time. So we'll pick that up. I think, I can't remember which item on the agenda. I think it's around item 9. So we'll agree specifics around that.
Okay. Is that okay, Ken? Thanks. The one other thing is the complaints performance for the first quarter 2023. That's in progress, so that'll probably come to the next meeting, will it? Yeah. Yeah, Dave.
Yeah, we'll do. But it's on track for that. Thanks.
Yeah. So can we maybe just put a date in there for whatever that is, the April meeting then? Is that April meeting?
Yeah, it'll be the April meeting, so I'll put that in.
Thanks. Okay, thanks, Dave. Martin, you still get your hand up, but you want to come back in? Is it a legacy hand, Martin?
My hand's down.
Is it? Oh, it's up in my screen. It's maybe my iPad is maybe running behind. So my apologies. Technology is a wonderful thing when it works. Okay, right. Arlene, take us forward.
Okay, so item 4 is Performance and Audit Committee. A is the minute of the previous meeting held on the 1st of February, which is submitted for information and record purposes. And item B, which is the Chair's Assurance Report.
Okay, thank you, Arlene. Ken, do you want to say anything here? This is your...
No, it's there in black and white, unless there's any questions.
Anybody get any questions for Ken on his Chair's Assurance Report or any issues in relation to the internal audit plan, the governance action plan, all the work that's going on in this committee? No. Okay, so I suppose it's just duly noted, Arlene, is that it?
Yep, that's correct. Thanks.
Okay.
So we'll move on to item 5, which is update on business model for older people with mental health needs, and you're asked to agree the recommendations.
Okay, so this is a sign off, right? Who's presenting this? Vicky?
Yes, thanks, Chair. I was just going to introduce
one of your missing people.
Yeah, so, well, not missing people, Jenny's
Not
on
missing
leave.
people.
However, we are joined by, I think Alison's on the call, Alison Lee. Yes, I can see her, in fact. So Alison's joined us today, who I think would be happy just to take any questions and provide a brief update if that's required.
Okay. Have we got any questions from members of the IJB on the papers? So you're not going to take us through this presentation?
Organisations.
Sorry? There's a presentation here, the Psychiatry of Old Age. This?
It's sorry, if I can just come in, it's just really for information. If
Right.
people,
Okay.
it was just for additional information if people wanted to have
good.
a look at it.
Yeah, I thought it was brilliant. I thought it was brilliant, actually. I thought it was great. It was really explained things to me. It's so much easier, I think, when you see it in PowerPoint somehow. I don't know if it's the ability to assimilate the information when it's broken down. But any questions? I've got 2 or 3 people with their hands up, and it's nice to welcome you to the meeting, Alison, and we're pleased to have you here. So I've got Dorothy.
Thank you.
Annie, and I don't know if that's Martin's hand up or not because it's not gone down on my screen. So I'll go to Dorothy.
It's Sarah. It's Sarah Dickey.
Oh, right. And Sarah, she's not on my screen, but anyway, thank you for keeping me right. So I've got Dorothy and Annie and Sarah in that order.
Thank you, Pat. I've got a couple of wee comments on the presentation. There was one bit that I didn't understand. It's labelled page 32, inpatient services, Kingsway Care. Complex needs have increased within inpatient environments as community services are supporting people at home longer. I really don't understand that. If someone could maybe explain. And I have another question on page 33, but if someone could explain the complex needs increase, please.
Alison, can you do that? Alison's frozen, I think.
Yeah, I think the connection's there. I don't know if Diane would wish to make any comment at this point, but essentially my understanding of it, Dorothy, is that we are now managing needs of a number of patients in terms of frailty and complexity in their own homes for longer. So those patients who do find themselves in an inpatient environment tend to be that much more complex in terms of their needs. But I think Alison is still frozen, but her hand's up. I don't know if you want to come in at all.
Sorry, I think we're having IT issues. I was completely thrown out there and back in, so I missed the actual question. Was it just about the complex needs within the wards?
Yeah, and how that's arrived at, you know, how people are being maintained at home for longer, and therefore by the time they're admitted, their needs are much greater because their acuity's higher.
Absolutely. And I think that's a natural progression with how people are being admitted to care homes as well. So we invested in our community teams in psychiatry of older age because people wanted to be at home longer. So we are managing more complex needs. So by the time people have to have an admission, they really have to have an admission and they need that level of expertise. So that's how we are now modelling our care. Dorothy, does that answer your question?
Yes, it does. Thank you.
Thank you.
It was just how it was worded. I didn't really quite understand. Can I ask my next question now, Pat? Page 33, the last item, in all wards, there's current difficulty recruiting mental health nurses, and there are 9 registered mental health nurse vacancies. What concerns me here is how do we ensure safe staffing levels?
Yeah,
with that number of vacancies.
It does pose challenges. It's a nationwide issue around RMN vacancies. So we feed this into our oversight organisations. We have completed reports highlighting it. There are different models being looked at as to how we do try and recruit. In terms of safe staffing daily, there is a huddle every day which looks at projected staffing levels and how that's managed across the site. And some very good team leads manage to make things work. I don't know how they do it, but they do manage it. Obviously, unfortunately, we do have to use some bank and agency staff. We're lucky to have people from our bank system that do come and work here very regularly, so know the wards, but obviously it's not ideal. We would like to recruit to our 9 vacancies. It's not for the want of trying. We've been out to advert several times and we will continue to try and look at that, but this is a national issue.
Okay.
Thank you, Alison. Could I just ask 9 vacancies in, across how many staff? What is the staff complement? So 9 out of how many?
Yeah. I don't have it in front of me, sorry, Dorothy, but I do have a breakdown. If I can come back to you because I've got a paper that I can bring up and have a look at.
Or email me, that would be good, Alison. Thank you.
Just email it around everybody. If you send it to Arlene, she'll make sure everybody on the IJB gets it. But it is a national problem, and we do go out and recruit everybody that's qualified. We go to the universities and we offer them all jobs before they graduate, and we try to get them in the door. And I know that nursing is very much all over that. I've got Annie and I've got Sarah.
It's not a question really, it's just to say that I had the privilege of spending an afternoon at Kingsway Care Centre and I was hugely impressed. The community mental health team, I think, is just an absolutely stellar example of interdisciplinary working and you've got, you know, OTs managing nurses and social workers managing. It just works, and the staff are really enthusiastic. And also the ward environment, as we've already indicated, these are people who have mostly dementia or severe and enduring mental health problems, but with added cognitive impairment. They're very challenging to look after, but the staff do an amazing job, and I think hats off to them. And I think Kingsway Care Centre's a brilliant example of a kind of service all on one site, but it works really well.
Thank you, Annie. Thank you for that. It's very positive. I'm sure everybody's appreciative of all the efforts that go in by the staff up there, Alison, to make that such a success. So if you could pass that on to people. I've got Sarah. Yes, I've got Sarah and then Ken.
Thank you very much, Chair. Thanks, Alison, for the paper today. It's just a point of clarification, please, if I may, on 4.1.9. where we start the paragraph by saying future considerations include the development of band roles. Can I clarify, is that the band 4 roles that you're referring to?
Sorry, Sarah, yeah,
no,
missing.
It's okay, because that helps with the context of the earlier question with Dorothy when you were talking about safe staffing, because these are some of the blended workforce that with the right skills and the right educational preparation to help support the wider team. Thank you.
Thank you, Sarah. Ken?
Just a brief comment. I think it's really notable that the wait time for non-urgent referrals is 7 to 14 days, with an average of 3 people at any one time on that list. That's despite the staffing problems that have been mentioned. I think that's fantastic. I wish we could replicate that across other areas of healthcare. So, yeah, well done.
Yeah,
thank you.
Yeah, thank you, Ken. Sam?
Partly just to say that it's pleasing to note, since it's not an observation, that the links have been established to the GP cluster meetings, because I think that's a good way of getting the message out, as opposed to trying with each practice, because the clusters tend to lead in a lot of these things, and that's very positive to see.
Yeah, that's good. It shows that the whole system is working, if you know what I mean. Great, thank you. Don't know if there are any more questions for Alison on this. It's a good paper. It's really good to see this update. Our role as a committee is to note the service provided within the psychology of old age services and the proposed direction, remitting the Chief Officer to provide an update report, and all of this work has taken place within the existing delegated budget for older people with mental health. So all we're really doing today is noting the update and recording that we're very pleased with that, and we're very grateful to all the staff that worked so hard to make it such a success. So well done, Alison. Keep doing the good work. And we're very appreciative of all of that. Moving on, Arlene.
Item 6, Protecting People Committee Annual Reports 2021 to 2022. These are for noting.
Okay, who's taking us through that?
Chair, I'll do that if that's okay. So I do that in my guise as Chief Social Work Officer rather than the Head of Health Community Care. So I think just I want to start by saying that the report really covers the annual reports from a number of our protecting people areas. So child protection, adult protection, violence against women, and the management of violence and violent and sexual offenders. And this is very much the first time I was bringing all the reports under a single cover, and to some extent really indicates the growing interface between all of our protecting people committees and how we work together and are actually starting to cross boundaries in terms of our consideration. The reports from represent a really huge amount of work that's been taken place during 2021 to 22 with a focus on prevention of harm to vulnerable citizens. And absolutely the Health and Social Care Partnership has a real part to play in delivering protecting people protecting people processes and procedures across the piece, and very much about working with our third sector and our other public sector partners in order to do that. So it details a number of areas, particularly focus on our trauma-informed practice responses to people at risk of harm, how we're using data and quality assurance information in order to improve the way that we work, and details a number of practice and service improvements across all of our sector areas. It also details some of the challenges that we've got in terms of our Protecting People Committee work, including our ability to kind of resource and our capacity to continue to support the work that we do, but also how we support the workforce to continue to both to protect people at a time when we're facing increasing demand for services and high level of need. So I'm really pleased to say that I've got a number of the independent chairs with us, and I can see both Elaine Torrance, who chairs our Child Protection Committee and our Adult Support and Protection Committee, is here. Anne Hamilton's also come on screen, who is working in terms of our violence against women. I'm not sure if Alan Small's here, but hoping he can attend, but if not, we can certainly be. Alan's not here, Catherine's shaking her head. Alan's not here, who does our map of work, but absolutely there's the people here who can provide both their personal experience of independent chairs and help kind of detail some of the questions that you might have. So happy to hand back to you, Pat, for any questions.
Thank you so much, Diane. So we've got a number of people here who are the experts in this field. We're happy to take our questions. So good morning to you all. Welcome to our IJB meeting. I'm going to throw open to colleagues on the IJB who've got any questions around some of the reports. No questions? No points? No clarification? I see Sarah's got her hand up. And Annie as well. Okay, Sarah?
No, sorry, Pat, I don't have my hand up for this particular report. Thank you.
Right, sorry. I've got Annie and then Dorothy.
I think, I mean, we had some of these reports at Care Governance recently, and again, I think I just want to say that people are doing a sterling job in very difficult circumstances, and really as the IJB, we should definitely pass on our thanks to everybody that's involved in this stellar work. And it's great to see it all coming together because it affects so many people in so many different ways. So I think it's great work and thank you. And it's very interesting reading.
I've got Dorothy.
Thanks, Pat. I would echo Annie's comments. We had a look at this at the council meeting this week. These are really good reports, very well laid out, easy to read, and just enough information to tell us what we need to know. Some of the graphics, you know, are really revealing. This one, I don't know if you can see it, this one that gives Scotland's, Dundee's position in relation to Scotland on a number of issues. While it's quite frightening in some ways, and when you see the depth of the problems that we're facing in our city, but very revealing. So thank you to whoever was involved in preparing these reports for us. And I think I said at the council meeting this week, I'm happy. It seems to me to make sense to bring these all together and produce one report at the end of the year. I was concerned that we might lose some of the detail, but I'm reassured when I look at the quality of these reports that if that quality is maintained, we'll know all we need to know, and we'll be, you know, well informed about what's going on and what the issues are. So thank you.
Thank you, Dorothy. Elaine, I think, wants to come in here.
Yeah, I'd just like to say thank you very much for those comments from both of the members of the IJB. That's really reassuring to hear. I'm the chair of the Adult Protection and the Child Protection Committee meetings. And yeah, just Dorothy's point there about assuring you that the work of the committees continues, the detail of the work in the committees continues. But I think we've made a lot of progress in the last year about joining the dots and making sure committees work together and looking the areas. For example, violence against women, there's a lot of overlaps there between the impact on children and young people, and indeed adults as well. So we're working really hard to find the areas where we can join things together, and therefore I think it's helpful that the reports come as a bundle, and you can see that, and also just to say we did offer a briefing as well. I think a number of people were able to attend, and I think that's really important, because then you can get a little bit more sense of the detail of these reports and some of the key issues that are in there. And I think if we continue to move forward and continue to offer a briefing, that gives an opportunity for a bit more in-depth look at these reports as well. So yeah, just but really good place to work, and just echo the workforce and staffing. You know, they do a brilliant job in quite difficult circumstances with quite difficult challenges. So just to say that too. So thank you.
Thank you, Elaine. Annie?
Can I just also say, Elaine, that multi-agency learning is really powerful. In a long time distant past, I used to chair the Fife Child Protection Committee, and some of our most stimulating events were the multi-agency training, and that was just for child protection. So if you extrapolate that up, I think that's a great way forward.
Yeah, and just to respond to that, yeah, we do an awful lot of multi-age. In fact, most of our learning is multi-agency. We've got a very detailed learning plan for learning and development plan for all of these committees and for all of the staff, and I absolutely agree. And also you'll see mention in the reports of case reviews. So when things don't go particularly well, we take the learning from that, and we're also auditing, making sure that those actions are implemented, and we know what the impact of that is. So yeah, you're absolutely right. It is about working together and partnership working right across the board. So I'll just echo that, and thank you.
Okay, thank you for that. I think one of the really important things about all of this is that a lot of places in the UK under financial pressure have disinvested in some of these very important services that you provide, and it's heartening to see that, you know, you were secured funding, funding was extended, you've established temporary domestic abuse, a manager post. The victim-centred approach fund has enabled you to develop domestic abuse court advocacy. So there's a lot of things there that are being funded, through the council that, are the things that you need. And a lot of places have not, recognised that, not been able to maintain it. So I think that's a really important issue. The other thing that I was struck by was the number of children on the child protection register because of parental mental health problems. And in a different world, we would maybe be able to accelerate the referrals for it could be a self referral, or it could be a GP referral for parental mental health, because in some ways it's a higher priority if you have children, because not only are you affecting your life and your life circumstances, but it's having a major impact on, could be several children at key points in their development. So I don't know if there's anything that we can do to promote that, because that's about health inequalities, because you need to bring these people up to a more level playing field. They need to get better access. If I'm at home and I live on my own and I'm suffering from depression and I need to be referred in, I'm important because I'm not well. But if I'm at home and I've got a mental health problem and I'm looking after 4 children, it almost feels like we should be doing a bit more to try and get them up the list, get them seen quicker. I don't know if that's a bit pie in the sky, but it just feels a bit like that they should be they should have some kind of priority rating against them. I don't know what other people think about that. I see Anne's got her hand up as well.
Well, I was just going to come back to your point about investment.
Funding. Yeah.
I think that's really important, because what we've managed to do in Dundee is bring in quite a significant amount of new investment. So we've now got the Court Advocacy Service, which we didn't have before. We've got CEDAR, which supports families who are recovering after domestic abuse. We have learning and development support. We're about to open a women's hub which will bring services together so that women, coming from women's views about what was important to them, we've got that going to be opening over the next year. So there's been significant investment. I think what we need to keep an eye on is that we can sustain all of those services over the longer term.
Yeah,
that's going to be really important. But from my point of view, I really see the priority given to the protecting people issues and obviously violence against women in particular. So I think that there's been a huge amount of progress in terms of seeing the links between the different issues, and that if we don't deal with them jointly, that we don't deal with them properly. So I think that's really, really important.
Thank you, Anne. And I see Elaine's got her hand up. Elaine.
It was just in response to your mental health discussion there, Pat, around, I guess people with mental health issues, whether they're living alone, there's a risk of suicide. You know, there's all sorts of different criteria and issues there that kind of, I guess, the service grapple with. Diane probably can speak to that better than I can. But just to note as well, we had a discussion at the council meeting. I think it was raised a little bit about the impact of the cost of living crisis as well on families and on people in terms of their bills and all of that. And I think that's another thing we need to keep a close eye on this year. How do we support people who have already got significant vulnerabilities, and on top of that they've got real worries and anxieties about, can they put food on the table and can they pay their electric bills or their gas bills? So I think that's another big pressure and something that we will need to be supporting. If we can support it in a preventative way, that shouldn't feed into the figures, but we'll need to keep a close eye on that and make sure that we continue to do that. Just a point there, Pat. Thank you.
Thank you. And Sam's just put something in the chat about the briefings being very helpful, Sam, haven't you? Yep. Okay. Okay, so I think we're just required to note these reports and note the good progress that's been made. And I think, you can go back with a resounding note of appreciation again for all your hard work, for the very innovative approaches that you've taken, for the investment you've been able to secure, the fact that you recognise that there's problems and needs and that you're responding to that. So it's a very, very positive view, I think, of the work going forward. So I'm grateful for your input and thank you for all your hard work. It's very greatly appreciated. Okay, thank you. Thank you very much. Okay, Arlene.
Item 7 is an agenda note on the implementation of the public sector equality duty. It's an update and it's for noting.
Okay, are there any questions on the update? Is this under your name, Dave? Who wrote this?
Catherine will pick up on that one.
Oh, Catherine's here. Where are you, Catherine? Oh, she's there. Oh. Good morning.
Morning.
Good morning. Are there any questions on the equality duty update note? There's going to be a briefing on the 1st of March, which is the one that Roger's doing. Everybody's got that in their diaries. Could I ask you all if you could please attend these briefings? We've got very senior people like Roger Many turning up and not a lot of people sometimes there. So I know we're all very busy, but if you could try and do that, that would be much appreciated. So we have an anticipated to ensure full compliance with PSED by Dundee IJB by the deadline 31st of March. So we look as if we're on track to do that, I think. Is that right, Catherine?
Yeah, I think we've got a couple, the briefing, as you mentioned, the briefing for report writers this week and some other small bits to tie up. But I think over the next couple of weeks, we'll be in a position to go back to them and assure them that we've taken steps to address the concerns that they raised previously and have that kind of fully in hand. Not to say we'll not continue to focus on that, and particularly around improving the quality of the content of integrated impact assessments, and that's what the work over the next couple of weeks is focusing on. So it's not to say that in the end of March that'll be us kind of finished and take our eye off that ball. We'll certainly be keeping a focus on it for the next wee while.
Thank you, Catherine. Dorothy, you got a question?
Yes, I appear to have lost my papers for this particular item. They're somewhere on my table, but I don't know. But I did last night when I was going through them, something did occur to me. So I do like integrated impact assessments. They're one of my things. So I know it's sad, isn't it? So Does this mean, Catherine, that following when this work's done, we will be receiving integrated impact assessments along with our reports, where that's appropriate for the IJB? Yes.
Yeah. So all reports must have a screening tool done. You don't receive those if the outcome of the screening tools, but as officers, all reports now must have a screening tool done, and where it's indicated that an impact assessment is required, that will be provided to you alongside your papers as part of the paper pack, in the same way that you'll receive those when you're in council meetings, Councillor McHugh. We will also be making sure that we publish those after the meeting, outside the pack of papers separately on our equality web pages, because one of the real issues that we had from the Equality and Human Rights Commission in relation to compliance was that it was difficult for members of the public to find those because they are in packs of papers. So we've also started the practice of publishing those separately and more clearly on the equality web pages to make sure anybody who would want to find them can find those easily, following on from the meetings too.
So, and there will be staff training, will there? I'm sure I've read this, but you can reassure me there'll be staff training in how to complete these, use the tool and complete the assessments.
Yeah, yes. So Joyce Barclay and myself are doing a briefing on Thursday morning, tomorrow morning, for people who are involved in report writing. There's also sources of ongoing support through myself and Joyce, but also Ross Craig from the council, their equalities officer, who's very good at providing support to us as an IJB as well. So sometimes these things, you can train people, but until they do it in practice, it doesn't kind of all fall into place. So there is that ongoing support as well as the kind of one-off briefings.
Thank you.
Okay, thank you for that, Catherine. If there are no other questions or points on this, we're just asked to note the position and note the deadline. And thank you for your helpful comment, Dorothy. That explains some of it in your response, Catherine. So IJB notes position on this issue. Okay, moving on, Arlene.
Item 8 is an agenda note on the Strategic Commissioning Plan update, and this is also for noting.
Okay, thank you for that. Are there any points or questions on this item, this update that we've got? I have one question, but I'm happy to wait if others want to come in. Dave?
Yeah, thanks, Pat. I was just going to kind of just give a brief update on this one, if you don't mind. So I appreciate you weren't able to kind of attend the briefing session that we've had on this one with IJB. So we had the kind of joint kind of budget briefing and strategic plan briefing as well. So just to say, we got some really good feedback from members at that meeting, the development session itself, and we've kind of reflected on some of those comments, and we've got a kind of further draft that we're kind of working to on that. We had a strategic planning advisory group at the beginning of this week, and again that was the main focus of the meeting. So again, we've got kind of good feedback, more comments, and a kind of really good kind of base to kind of take this one on further. I think what was reflected back at the briefing session itself was that the plan, this plan is going to be very different looking from previous plans. It will be focused on, it'll be something that's very public facing, that's written for the public and not for us as officers and kind of members, etc. So it will have a kind of different kind of look and feel about it from before, and that remains our kind of focus over the next kind of couple of months, with a view to still hitting a kind of April deadline for kind of setting this out for the IJB in terms of a report at the April kind of meeting. So yeah, progress continues. Kind of just like to kind of thank Catherine and Joyce Barclay in particular for all their work on this. They're kind of putting a power of work behind producing this very kind of complex in terms of pulling everything together. It will kind of look a lot different, as I said, in terms of the messages that are out there. So things are on track, but it is still, just to note, it's still a kind of challenge resource-wise for that.
Thank you, Dave. Thank you for that update. If no one else has got their hand up, I've got a couple of questions, and that's maybe my fault because I missed the briefing, but I was tied up that day. But the exercise to review and benchmark against strategic commissioning plans of other areas of Scotland. Did that yield anything different, Catherine? Did that throw up anything that made us think, well, here's something that we're not doing, or maybe we should think about that, or we're out of kilter on this, or we're way ahead of the pack on that? Were there any kind of learning outcomes from that?
I think there was a few things. I mean, it's always helpful to look at it and kind of take the best of bits, particularly around some of the kind of formatting and style of it. So there are certainly some reports that are more public facing than our previous strategies have been, so it was useful to see that. Some that are less so. There was one in particular that I think Tony Gaskin had pointed us towards and felt was helpful from a kind of internal audit point of view, so we had a good look at that in terms of, and a lot of that I suspect from Tony's perspective was about how they'd spoken about risk and the influence of risk on their plan, both in terms of priorities and delivery. There were some things around how people articulated an ambition rather than a vision, and things around values and principles that we've pulled through and spoke to IJB members at the development session around as well. And there was certainly some learning about presentation of information and kind of graphic formats that people had used in summarising some quite complex information, including some of the national policy. So it was useful. I think the strategies all look to some extent similar but different, so I don't think there was anything that was significant. We were a significant outlier around, but we certainly have taken bits from various places, so it was a useful exercise to go through and to have a look at. We also had a focus on some of the areas. Glasgow in particular have quite recently refreshed and replaced their plans, so some of the more recent ones we paid more attention to, because obviously they're not quite as dated as some of the ones people who are in our position who've had a strategy for a while. So it was a good use of time to have a look at those.
And my other question, Catherine, thank you for responding to that. My other question is, one of the things you mentioned in bullet 1, 2, 3, 4, 5, 6, I think it is on page 4, is you talk about contributions and ongoing engagement relating to the GP premises strategy. So will GP premises and GP practice sustainability be a big feature of this commissioning plan?
So I think we're still working through what we're going to pull into the main plan from some of the existing strategies, including primary care and the premises and workforce strategies, those sides of it. But yes, I would expect that would feature. In terms of the consultation, I think that was really about us making best value of the quite limited resources that we have. So Joyce Barclay was able to link up with Julia Martin now to go and speak to people once rather than asking them, which I appreciate is really irritating when we as an organisation ask them one set of questions about one thing and want to go back the next week and do that. But actually, as an approach, that worked really well and managed to help us to engage with maybe audiences who perhaps wouldn't have necessarily taken up the offer to speak broadly about the strategic plan, but did want to talk about GP premises. And in doing so, we were able to gain some wider information. So we're working closely with Shona after the meeting on Monday as well. She was there to kind of think about the GP elements. But yeah, I suspect sustainability and premises will be a feature as we kind of work through exactly what that looks like in the high level plan and then into the delivery plan for some of the detail as well.
And will the delivery plan be neighbourhood based or cluster based, or how will that?
I think we're still looking at exactly how we might split that up. I think it will be around split across the priorities in terms of setting out the detail of how we'll achieve some of the outcomes and the overarching strategic framework. But I think within that there would definitely be options for us to look at things that are system wide and some things that are locality based as well.
Okay.
Yeah. Particularly around some of the inequality elements as well, where that might be most relevant.
Yeah, given the last agenda item, that would that would fit well. Okay, if we have no other questions, I think we as an IJB are just asked to note the position or update on the strategic commissioning plan. So we look forward. It's going to be developed by the end of April. So when will it come to the IJB?
So, sorry, Pat. The aim is to kind of deliver it to the April IJB itself. So that's what we're kind of looking to do. And then we've got, as kind of noted there, there's some other kind of companion documents that we're suggesting would then kind of follow kind of later dates, because we want to focus on the actual plan itself, and the companion documents are not essential to be kind of input at that point as well. So
okay. And give us plenty of opportunity to read that ahead of the meeting.
Yeah, I mean, I've not spoken to Catherine about this in terms of
Thank you.
process,
That's great.
but I've not spoken to Catherine in terms of that kind of process, but I'm envisaging that we would send out drafts kind of before you actually get a final version, because I don't think it's helpful to just get a version and say, could you approve this, please? So you need to kind of get something, but kind of in advance of that.
This is such an important document for us because it sets the priorities and the direction of travel for the next, what, 3 years? Is it 3 to 5 years?
Yeah, 10.
10 years. Oh, well, even more important. So 10 years. So give us all an opportunity to go through it, because people like to reflect on things as well after they've read them once. So thank you for that, Catherine. Arlene?
Item 9 is the Dundee Alcohol and Drugs Partnership Strategic Framework and Delivery Plan, and you're asked to agree the recommendations.
Chair, I'm happy to take this
Okay,
item.
is that Diane?
Yeah, John Wiley, who is the independent chair of the Alcohol and Drug Partnership, was actually due to be here this morning to present the paper, but unfortunately it's had to be called away. So I'm happy to present it. Just a couple of things, and by way of introduction, the Alcohol and Drug Partnership strategy is actually signed off by the Chief Officer Group, so it's coming here for information only at this point in time, and that's because it's very much a partnership report that requires on a number of partners across the piece to be able to support and develop and work through. So it's coming for us for information. It also went to the Policy and Resources Committee of Dundee City Council on Monday night for information as well. A couple of things to highlight. The report is obviously, or the strategy should I say, is also drawing on all the information that we've had for the last number of years, both in relation to the Drugs Commission report, the work that we need to do in terms of national strategies, the MAT standards in terms of being able to deliver on those, and has pulled all that in together in terms of a strategy that spans over 3 years. We're looking at that to really start to move on and build on a lot of the work that we've been doing already in terms of going forward. And we want to start to get to a position where we have a single action plan that pulls together all those different streams of work into a way of actually presenting what we're going to do. There are a number of things that will fall out of this action plan. There's a commitment to develop a delivery plan, but also have that bedded and fixed within our financial and commissioning statement. So Dave particularly leads the strategic commissioning group, which is actually looking at how we utilise the resources that we have in their entirety to deliver the services that we want. We're also looking at developing measurements which allow us to actually monitor and measure the progress that we're making over the next few years so that we can demonstrate the work that is going on. So it's there really for your information at this time. We're happy to answer any questions. I have to acknowledge Catherine and Vered, who did a huge amount of work in actually pulling this strategy together, but more than delighted to answer any questions that you might have.
Thank you, Diane. Thank you for this. Questions from IJB members? Dorothy's got her hand up. Dorothy?
I think Raymond had his hand up before me. Pat, maybe he.
I'm not seeing Raymond. I'm on an iPad, so my apologies.
Happy for Dorothy to. My question was just, Chair, in relation to. I mean, I understand that this is for information, so I suppose the elements of this paper which directly affect staff and staff's terms and conditions. I'd like to understand where that would then be reported and how we will see that. And a specific question as well would be around Constitution House, because it indicates there that there's been a preferred site or potentially a suitable site. So when's those discussions going to, are they been having with staff, and also what is that suitable site that's been indicated?
So Raymond, I think I'm happy to come in, Pat. Is that all right?
Yeah,
so to answer the last question first, I think I think you were maybe late in coming to the meeting because we discussed that early on. We are looking at the Wallerstown site in terms of the clinical aspect of the service to be able to deliver some of the work that we need to do. So that's just in part of the service, Raymond. Once we see whether or not that's available, then we'll do that. We already have staff there, so we're used to working from there. But I'm happy to take a fuller conversation with you. I'll pick up on that one gone out with. In relation to terms and conditions, so obviously this comes to the IJB because we deliver part of those services directly. So any issues in relation to staff terms and conditions or impact on staff would be managed by the Health and Social Care Partnership in the normal way. So that wouldn't be impacting on the strategy. We would manage that in a normal way as part of our contribution, and I can again pick that up again with you if you want.
Okay, are you happy with that, Graham? Raymond, sorry, are you happy with that response? Yep.
Yeah, thanks, Chair.
Okay, thank you. So I've got Dorothy and I've got Ken wanting to come in, so I'll go to you, Dorothy.
Thank you. As Diane had said, we had a look at this at the Policy and Resources meeting the other evening. Was it just last night? Can't even remember. Could I ask you, Diane, page 224 on the, I think it's the delivery plan, there on the strategic framework. Page 224, the last paragraph refers to the Drugs Commission recommendations and says this commitment and the recommendations made by the Commission are reflected within the strategic framework. I couldn't really identify them as such within the framework or within the delivery plan, you know, specifically. And considering, you know, we had an initial, 12 recommendations, and then later on the review report, an extra, was it 16? I'm not sure of the numbers, maybe wrong. I think it's quite important that we do reflect directly on the Drugs Commission recommendations within these documents.
Dorothy, I'm happy to start in terms of response, but I can see that Catherine has also come in and I would be wanting to hand over to her. So I think there's a couple of things. One is the issue in relation to this as an alcohol and drug strategy and not just a drug strategy, and very much the Commission reflects on only drugs. So we need to get to a position where we're reflecting all of the work of the ADP and actually starting to think through how do we build that into the strategy. There have also been things which actually supersede the Drugs Commission. So a lot of the issues that were reported within the Drugs Commission, so I use, for example, things like same-day access, GPs, the interface between mental health and substance use, all of those have been superseded by the MAT standards, which actually now take some of those recommendations, define them in terms of the way that we have to deliver them, and then actually work them through. So to some extent, they're out of date with what has happened in terms of further work, albeit the principle is still there. So we need to be able to keep moving the strategy in a way that actually doesn't lose sight of what happened in the Drugs Commission, but actually moves it to the current thinking and the current way of working. So where you're seeing that, if we kept trying to reference back to every single documentation, we would end up with a very complex and clunky work. So what we've made sure is that we incorporate all of those actions and update them in relation to current thinking and then reflect them through the strategy. But Catherine, I know you've done a particular piece of work to do that mapping, and do you want to come in?
Yeah, thanks, Diane. I was just going to say that we have done some mapping just to set out for people in a very clear way how the original recommendations from both the Drug Commission reports are reflected in the strategy, just to give that assurance that they have been covered. I'm happy to recirculate that again to IJB members out with in this meeting. It was part of a previous briefing provided to you, but can send that out and certainly highlight where that is in that document to enable people to have a look at that. And then if there's any further questions, I'm happy to take those and speak with people in more detail off table. So the language may well be slightly different in terms of what's in the strategy, but it sets out that kind of clear mapping between the commitments in the strategy and the previous recommendations.
Thank you, Catherine. Thank you.
Okay, you happy with that, Dorothy? Yeah, okay. I've got Ken wishing to come in here. Ken?
Yeah, I've got a couple of questions, but first an observation. We often hear talk of the Drug Commission recommendations. In actual fact, that they're not recommendations, they're in effect action points now, given that all the relevant bodies have agreed to it, the recommendations lock, stock and barrel. So I think it's important to make that distinction. They're not recommendations, they're in effect action points. So yeah, my first question was about the residential rehabilitation pathway. I realise that hasn't been up and running for long, only since October 2022, but I see there are 17 people currently on that pathway, but it doesn't say how many are close to getting the care they require, whether that be residential or in the community, which is better for some people that residential rehab. And also in terms of best practice, what would we be aiming for in terms of someone coming to us with a mind to go into residential rehab and them actually being placed in residential rehab?
I'm happy to answer that, Pat. So in regards to the pathway,
Before you answer that, can I add on to that, Diane? Where is that residential rehab? Where is it being provided? That was one of my questions. If I could add on to Ken's list. Sorry,
Yes,
Diane.
certainly. No, that's okay. So if I try and kind of break that down. So in terms of the pathway is very much about working with people to enable them to be prepared to go to residential rehab if that's what the final outcome is. So while we've got 17 people on that pathway right now, and it's a very new pathway, so we are developing and working on that, that's not to say that 17 people would ultimately make the decision to go to residential rehabilitation. Some people might choose to stay. Some people might actually be in a position where understanding kind of what that might mean will make them feel that they're not ready yet to go, and so we'll work with them for a longer period of time. So we would be doing that on an individual basis, Ken. So it's almost impossible to say of that 17, 12 will go to residential rehabilitation, because it is actually about really getting to understand what they need, what's going to be best for them, and how they best take that forward. What we would be saying is that we've got a budget for residential rehabilitation. We'll be working to that budget. If we get to a position where that budget runs out, then we need to have a different type of conversation, but we're not there yet in terms of the numbers. And I think it's something like 20 placements if you look at the minimum amount of time that people might go. So for example, a 12-week placement. When you start getting into longer placements, more complex situation, obviously the distribution of the funds then become less. So it is very much about that. And this is because we know that people quite often have unrealistic understanding of what residential might mean. They might not have the support networks in place to enable them to get ready to go and to be safe before they go, in terms of how we would work with them. But it's also about making sure that when people are in residential rehabilitation and when they're coming out of residential rehabilitation, that they've got that full pathway support all the way through each stages of that. And that probably wasn't there before. So if somebody was suddenly discharged because a placement had not worked out as well, they were quite often felt floundering because they were trying to get back into services again. So it's about the whole pathway, and that's why we've developed that. In relation to the numbers, I think it becomes quite tricky when your numbers are quite small, and they are quite small, to start naming the people. And also we need to differentiate from those who have been in residential before the pathway was put in place. So it's quite tricky, but we're more than happy to provide updates out with the public forum to if as and when we start to produce that data, and when it's relevant to bring it back into public forum. So that would be that aspect of it. In relation to where people go, well, it's always been about choice. Choice is based on the availability of services. That can be anywhere in Scotland and in England. At this time, we don't have a residential rehabilitation of that nature in Dundee. We do have the Children and Families Unit, though, at Cowan Grove, which can only take up to four women, but we do have that as an option for people in Dundee. There's always been a mix of views in whether or not people want to stay closer to home or actually want a complete break from the environment they're in, the temptations. So we need to work with people as to what we can do, and different residentials provide different types of support. So it'll also depend on the needs of the individual as to where they go. I don't know, Pat or Ken, if there's anything else you would want to ask on the back of that.
No, I'm fairly encouraged by what you say about we've got funding for 20 places, although only at the minimum of 12 weeks. I guess I'd just be keen to know how soon we're going to start actually placing people, and what's best practice. If once someone with the decision has been made that they're suitable for residential rehab, how quickly should they? Because presumably, how long is the assessment period?
The assessment period is so we've never stopped placing people. This is not built in a barrier. The assessment is very much based on individual, Ken, and so it will depend on individuals. And some people will come ready now, and everything that we do and work with them means that they'll move quite quickly through that pathway aspect. Some people won't. And we'll need a lot of work and support to get to that position where they're ready to take that step. We want these to be successful placements and not placements that fail, if I could put it as crudely as that. So it's about building and working with people to make sure they get the best out of the opportunity.
Thank you. And just finally, I know I'm always asking about Constitution House, but this isn't a hostile question. I'm just wondering what are the criteria for this new building or buildings? And I say buildings because I don't think we ever said that we're just going to move Constitution House somewhere else. We were hoping to disperse the services that are provided there through the city. That's my understanding. So yeah, what are the criteria? And in terms of Wallace-Town, which seems to have been identified as possible, how suitable is that building, and would there be a lot of work required? And that's all my questions now.
So yeah, so in terms of, so first of all, you're right in terms of the work. So there are two aspects to this, and one which I think was picked up through the Drug Commission, which was about much closer working between statutory treatment specialist staff and third sector, and how we do that and how we manage that. And so what would that look like and what would that mean? And that's the aspect of how we need to deliver our services differently. But the bit that probably wasn't as accurately recognised was just the fact that when you are delivering clinical treatment services, there are certain aspects that need to be included within that. And I think you've heard me say before, Ken, and you heard me say earlier on, that includes things like a home office licence to be able to deliver certain types of medications. So Buvidal comes under the Drugs Act in terms of being defined, I think it's category 1 or 2, I can't remember, but it's defined. So you need to be able to have a home office licence in order to store that medication and then administer that medication. And that home office licence is linked to the building and not necessarily to the service. And we've had significant difficulties in managing that and keeping that service going when we had the issue that we had within Constitution House recently. So we need to look at that, and that's why it needs to be a base where we can actually license that building and deliver those services. And that's a 5-day-a-week service. We have other aspects and things like the drop-in clinics. So we're looking at different ways of delivering drop-in, one about which is how you deliver those treatment aspects, so the same-day prescribing, but equally thinking about how on earth do you deliver things on a Friday, for example, when we wouldn't do same-day prescribing, and the MIS team have recognised that's not appropriate. Somebody comes in at 5 o'clock trying to get a prescription and a pharmacy to take that on is just impossible. So, but how do we continue to have a support service where people 5 days a week for drop-in? And so we're working with our third sector colleagues to look at that in a slightly different way. So we're already making some of those moves and interventions. Once we know what we've got in terms of clinical, we can deal with that. And in terms of the building itself, I think it will need some work done, and we'll need to have some of those conversations. And that's the work that we're currently pulling together just now to map out what we need. Probably looking at kind of, I think, probably May, June, July times before we'd be able to manage that shift, if not, depending on how much work we need to do.
So, sorry, I do have a supplementary. There are 70 staff. How many spaces are freed up by the GP moving out?
No, it won't cover anything like that. It won't cover anything like 70 staff. And because of the range of the staff, we need to look at where we're working from elsewhere to consider how we do that. So we've got staff based in some health centres, for example, that work from there. We've got spaces and offices across Scotland, across Dundee. You know, so we need to look at the entirety of a resource, but we couldn't do that until we knew how we were going to be able to deliver these clinical aspects. And then what would that mean? Where would that be? If, for example, we had a building where you could do that and you could have a mixed group of staff to deliver ongoing services, that would be great. But that's not where we are at this point in time.
How many staff are currently working at Constitution House? That's the absolutely final question.
So I say 70, but I'm sure that'll vary up and down. But it's approximately 70 staff actually are based in offices in Constitution House, and we haven't actually returned to the maximum number of staff. So our social workers, for example, as part of COVID, actually moved out of the building to allow some of that space to take place. But I also have staff in Wallace-Town as well.
Okay. Thank you, Ken. Thank you, Diane, for your responses. I see Vicky and Catherine have both got their hands up. Is that right?
Yeah,
if I could just come,
yeah, if I could come in briefly, and I'm conscious that for other reasons, the new independent chair of the ADP John hasn't been able to join us today, but one thing I wanted to do as part of our meeting is recognise the contribution that John has made to the ADP and the leadership that's now present across the agenda. One thing he did mention when he attended the Policy and Resources Committee on Monday night was recognition of the significant amount of work that's been put in by all of the frontline teams, and those include our staff who work with the Drug and Alcohol Service, particularly as Diane's referenced through a period of time that's been pretty constant actually over a number of years, where they may have felt quite criticised for the work that they do, but also have been under pretty much continuous scrutiny, really as a result of a whole range of different issues, not necessarily just the work of the Drug Commission, but there's been a national understandable spotlight on the work that we do in this area. So I just wanted to kind of almost replicate those thoughts today at our IJB and offer formal thanks to all of the frontline staff. Even the last few months with the additional buildings issues that we've had at Constitution House, we've had unwavering support. We've had staff cancel their leave to try and make the service work, but also to try and build a service that can respond really positively to all the new MAT standards that have emerged. So if that's okay with you, Chair, I just wanted that to be noted and recognised today, because I think they've done a phenomenal job, Diane and all her team included as well.
Thank you. Well, I think that's really important that we recognise the when staff go, beyond what the general day-to-day job description is, and obviously they have to keep this whole show on the road. I don't know who else has got a hand up. I think Catherine maybe is. I don't know if Sarah's got her hand up, or is that Martin?
Thank you, Chair.
It's difficult for me to see on a small. Sarah?
Yeah, thank you, Chair. It is mine hand that's up. It was really just coming in on the back of Vicky's sharing of staff going the extra mile, and it was just a point to share with members of the board that not only is this a team that goes the extra mile, but in amongst all of the adversity that they faced, one of the senior nurses has been successful in securing a place on the prestigious Queen's Nursing Institute for Scotland programme, and he'll start that programme next month. So these are staff that are really creative, innovative and agile around what they need to do to meet the needs of patients. So really looking forward to supporting her on that programme. Thanks.
Thing to achieve, so we wish her all the best, and we would like to congratulate.
You're freezing again. You're frozen.
Yeah, can't hear at all.
She just signed out, maybe if she signs in again, otherwise I'll need to take over.
She's been having ongoing IT problems, Ken, for a wee while.
Here she comes, I think. Yep.
Can you hear me now?
Yay!
Am I unfrozen?
Yes.
Probably.
No. No, you're not. You're frozen again.
Frozen.
Ken, you're on.
Yeah, I don't want it to be on though. We're going to give her a minute.
Yeah.
Suggestion, Ken, that we take a 5-minute break, give her a chance to come back in.
Well, that's not a bad
good idea.
Yeah, that's a good idea. Yeah.
Coffee.
We should be taking a break anyway. I hope Pat can hear that and doesn't think we've just all abandoned her.
Right, quick coffee.
Yeah, okay. So I'll leave my screen on and keep watching the screen in case Pat comes back. So yeah, 11:20. Yeah.
So thank you for that. Okay, there were no more questions on mental on the substance, alcohol and drugs partnership strategic framework. Are there any more questions?
Nope.
Well, as one of the cities in the UK with one of the biggest drug substance use problems, I do think at some point we need to create some kind of integrated centre, which would be a replacement maybe for Constitution House longer term. This wouldn't be short term, this would be longer term, but also would provide us with our own inpatient rehabilitation beds, because I see that in all of your documents in the 2-year delivery plan, that's one of your key outcomes is to report on the effectiveness to progress the model of rehabilitation support in the community. And there's obviously different, options for different patients, might need different things. Some people might need to be close to home, some people might not, so we might still need to commission people out of area. But I think we should be looking for substantial government investment in this very important service, given all the really good work that's gone on and the progress, Diane, that has been made and the effort that people have put into doing that. I think there needs to be some capital investment. I mean, we can build a National Elective Care Centre in Perth at 100 million. Why can't we? That's this has been recorded. It's not really for minuting, but we should be able to invest similar amounts of money in a service like this and have state-of-the-art, purpose-built facilities that and not be trying to adapt things all the time, old buildings and maybe unsuitable premises. We need to put together a business case and have an integrated drug and alcohol treatment centre or something, you could call it that, with the inpatient beds and the rehab maybe on the same site. There was an attractive, nice place for people to come into. They deserve to have the best facilities, the nicest environment, just as everybody else does, so I think we need to be pushing that as an IJB. I'd like to see something coming forward saying that we've got a business case or we've got a team or we've got resource to put that together. And I think we probably would be knocking at an open door with the Minister for Drugs and Alcohol. So I'd like maybe to discuss that out with a meeting, maybe with Diane and Dave and Vicky and Ken. I know it's a matter close to your heart, Ken, in terms of taking forward the recommendations of the Dundee Drug Commission, making sure that we move forward with this. Thank you for indulging me. So we are asked to note the content of the report, note the intention of the ADP to develop the performance framework, the investment plan strategic risk register, note the areas of progress achieved over the last 6 months, and instruct the Chief Officer to bring forward further updates as we move forward in line with public reporting schedules. So if everybody's happy with that, I take it we are duly noted. Thank you. I'm sorry I lost connection with you all. I hope you had a chance to make a cup of coffee. I certainly did. So moving on, Arlene.
Item 10, Mental Health and Wellbeing Strategic Update. This is for noting.
Okay.
Pat, I'm going to introduce this report, if that's okay.
Thank
But I
you.
do have colleagues on the call that I'll kind of pull in. So just first of all, to acknowledge this work is Arlene Mitchell's work, but she's not able to be here today. So really just to highlight, what you've got is a very detailed report in front of you, which actually lists a lot of the strategic work that's gone on recently, including a number of the new initiatives. There's a few things I would want to highlight. The report actually starts off with an update in relation to the work that was done in response to Professor Strang's report. There has been an independent oversight and assessment group that's been in place monitoring and looking at how that work has been progressed, and they have now published their report. That was published in January. They looked at progress against the 49 referral points that were made in the original report and have reflected back both the improvement in the work that has progressed, but also some areas of continued attention that needs to be looked at. They have actually now identified 6 key areas that they want us to focus on, and those are recorded in the report, and there's to be a delivery plan that needs to be back with them by the 31st of March in terms of government. So work is ongoing in relation to that. The report actually highlights some of the really good work that Ali and her team have done in relation to distress brief intervention, but also the mental health discharge hub as areas of really good practice. So that added to a number of the areas of work that we're doing already has been really welcomed and well deserved. The report also talks about and gives an update in terms of the Community Wellbeing Centre, and I think we've touched on that already this morning in terms of the progress made, but you can see good recruitment, actually bucking the trend in terms of recruitment in order to build up the team, and there'll be a phased approach to taking that in. And I think the work that we've also done around things like the Navigator, the inequalities work that Linda and Sheila have been leading on, and also the primary care engagement, that again, some additional funding has come through and some recruitment in relation to that. The report also touches on an area which I know has been of interest to the IJB over the last number of months, and that's in relation to the suicide strategy. So we now have the national strategy which has come out, and there's been a lot of engagement both at a national, local and Teesside level to consider how we might take that forward, including the recruitment of a coordinator on behalf of Dundee to be able to implement some of that work. And I think one of the other key things to say is that suicide prevention has now been very much set in the remit and responsibility of chief officers, and in addition the chief officers group. So a paper was actually taken to the COG just last week, setting that out, explaining how that responsibility is now to sit within that much higher level kind of oversight and what we think we need to do going forward. So I know that colleagues are looking to bring a paper in the very near future in terms of describing in more detail the strategy around suicide prevention. And I believe that Linda Graham and Sheila Allen are both on the call, who've been absolutely heavily involved in detailing this, and hopefully will be able to answer some of the questions. Thank you.
Thank you, Diane. Questions and comments from colleagues? I see Annie's got her hand up, and I don't know who else that is. Is that who's SD? It's Sarah. Sorry, Annie, and then Sarah.
Hi. It's
and
a
Martin.
fascinating paper. I think there's an awful lot of operational detail rather than the high level strategic stuff, and there is a risk that those of us that are interested can get in amongst the weeds, but it's fascinating. I was particularly interested, Diane, in the fact that Penumbra, who won the contract as a third sector organisation, seem to have had huge success in recruitment, whereas us NHS folk can't. So is there learning in there for us? But also, I think it's great to see that we've got people with lived experience involved in interviews for senior posts, and it's great to see that we've got peer support workers coming on board. So lots of detail, lots of good work, and it's great to see it all put down in one place. Thank you.
Okay. I don't think we need to respond to that. We're just noting that you're very pleased with it also. Thanks, Annie. Thank you. So I've got Sarah and I've got Martin. Sarah.
Thank you, Chair. Really welcome the paper, Diane. Thank you very much. Really comprehensive in terms of the range of service provision for people. My inquiry is, and it wouldn't be any surprise to Arlene, is in my role as Executive Armed Forces Champion, and I was, I suppose, just slightly disappointed not to see the synergies across for those from our armed forces communities, be that veterans, serving personnel or families, and particularly in light of the wider mental health action plan work that's going on through Charles with Stanley at the Scottish Government. So my only observation would be it'd be good to see that read across to the work. And I know Dr. Ramage has previously presented as clinical lead for V1Ps at the IJB previously, so it'd be good to see some closer alignment in the papers. Thank you.
Thank you for that, Sarah.
I could see, sorry for interrupting, I could see Linda's put her hand up, and I think she would probably want to respond to Sarah.
Yeah, where are you, Linda? Here you are. Good morning, Linda. Nice to see you.
Well spotted. Thank you for the question, Sarah. Apologies. We tend to report on Veterans First Point when we come with the psychological therapies update, because those services are hosted within MAPS with Dr. Ramage, as you describe, comes under our PTS family. So we report through there as opposed to within the mental health base.
Okay, thank you. Yeah, just in terms of a follow on, then accepting that position in terms of V1P and the psychology, there is the wider aspects of mental health and well-being for those in our communities from the armed forces. So for those that aren't reaching out to V1P, I still would like to see some sort of connection and synergy.
Can I just ask a question here, Sarah? When you're discharged from the armed forces, do you still have access to the special services that provide when you're a serving member of the armed forces? Is there a period of time where they don't just become part of the general community with ill health, or do they continue to get kind of better access or special access because of the trauma maybe that people have been through?
So there's lots of detail within in that response part. So there's the covenant aspects, which is the legal basis for which we provide provision for those from armed forces, but also there's very clear transition processes to support people who are leaving the military permanently to enable them to adapt and adjust to civilian life, and that's at least a year. Transition period. So there's a lot of conversations take time: employment, housing, benefits, access to healthcare, registering with a GP, and transitioning from the military medical care that they receive. So there's quite a lot of focus in that transition period for the armed forces. Yeah.
Okay, thank you so much, Sarah.
Thanks.
Linda, did you want to come back in? No.
I didn't, thanks, Pat.
No. Martin.
Thanks, Chair. Just to say on this item, Anne made reference to the recruitment and selection process. I've been heavily involved in that process from the start. I was one of the two people who with lived experience have been involved in recruiting all staff from the most senior member, Emma Wilson, down to the most junior post. And that's still ongoing because there's still spaces left and they are still in the process of recruiting more. I just want to say I think one of the reasons why they've been very successful in recruiting is because it's the whole mindset of the organisation, the whole mindset of the way they want to develop the centre, and it's attracting people with the experiences of mental health themselves, and they've also attracted people with professional qualifications as well in areas like psychiatry and other areas of that nature. So there is a lot of synergies that are going on at the moment in terms of the staff that are being recruited. We've even been able to they've even been able to recruit staff from DBVA in a senior managerial role. So they've been able to pull people with ongoing and current knowledge and experience of the centre. So that's also helped in that aspect. As I said, I've been heavily involved in the way that doing the interviews. The system that they operate, very briefly, is an informal session in the formal interview process. I'm the informal side, so I get to sit with them for 5-10 minutes, have a chat, work out what they are as a person, and make sure that in my mind, that they are what we want as a person in terms of the mindset and the mentality that they're bringing to the centre. I want because one of the things I want to make sure is that the people that are employed are the people that we want, not as per number ones, but also as the health and social care partnership we want in that place to deliver the service that we're looking for. So it's been very successful. It's ongoing at the moment, and I'm hoping realistically by the end of May, we should have everyone in place and everything up and running.
Okay, thank you for that. Thank you for that, Martin. That's very helpful. Linda, did you want to come in here? No. Linda, are you there?
I am here, Pat. No, I don't think I have anything additional to add.
Right, okay. Are there any other questions or points? I've got a few things I wanted to ask. So the mental health response unit, I thought the statistics were really interesting. Well, there was a couple of things. One was in the DBI service. Is that just still in one cluster, or is that being rolled out? I think it says in the paper somewhere that's been rolled. I couldn't find it. As Annie said, it's quite a complex paper. I couldn't find the section where I think it said it was being, the DBI service was being rolled out from into different clusters. Is that right, Diane? Or is it already in all the GP clusters?
I think Linda can come in and answer that one, Pat.
Linda?
I can. So Pat, that is a kind of combination of the plan and where there's capacity.
Right.
So we certainly moved beyond the first kind of cluster, and I think the next GP cluster wasn't using with a high frequency. So my understanding when we had agreement to move to the next, whilst working with the existing clusters to make sure they're maximising the resource that's there, and alongside that thinking about what other sort of service areas are around who might also be able to make use of referring into to DBI. So our ethos is that we need obviously to maximise the number of people who are benefiting from
Right.
that. Therefore, we make decisions as we go when we're seeing the capacity for that.
Okay, thanks, Linda. And the other point I wanted to make was the mental health response vehicle, now staffed and fully operational 7 days a week. That's wonderful. And that the admission rate, the weekly percentage of people taken to hospital was 22.5% compared to the weekly average percentage of people taken to hospital with a standard ambulance was 56.8%. So you can see right away that when you get, you know, immediate on-site people who understand mental health and can help the patient there and then, the admission rate, because nobody wants to end up being admitted to hospital if they can avoid it. They want to be at home with their families in the places they know, in the communities where people love them and care for them. So I think that's a really good statistic, and I hope, if you don't mind, and we might use that in our meeting with Scottish Government tomorrow afternoon, just to demonstrate. It's always good to throw some good statistics in here, but also not to be flippant, but also to congratulate all the staff involved for that initiative. It truly is groundbreaking, and it's heartening to see that. So I hope that the evaluation of this pilot will continue to be rolled out. Linda, did you want to come back in?
I did. It was always with the data kind of caveat, Pat, that the numbers aren't significant because they were only analysing
small numbers. Yeah,
you know,
so percentages. I didn't ask you for the numbers, but I like the percentages. Yes.
Site. So we are keen to get Dundee specific figures as soon as Scottish Ambulance Service can provide those.
Right.
Having had a look at some of the raw data, I think one of the key questions that needs to sit alongside the good news story, which you're right highlighting, is that we're equally seeing a number of people who are then having more than one contact with the paramedic response unit.
Yeah.
And that we don't want simply to be shifting the work but not solving the problems that people have.
Yes, a bit like repeated admissions.
Absolutely.
Yeah. Are we discharging too soon because they're being repeated admissions? Yeah.
So a very keen eye on what the actual outcomes for people are. Because obviously keen that we're not simply leaving people at home having assessed that they don't need anything immediately in that moment, but I'm putting in sort of follow-up that means that people are getting the help they truly need.
It's a bit like admissions to hospital. Sometimes when the admissions rate goes up, it's just because people need to be admitted, and there's no way around that. You know that, and it will be the same in mental health. There'll be periods where things get really difficult, and you might see more people being admitted. Percentages might go up. So, but I think overall it's got to be a good thing because it comes out and looks after you and assesses you, as it were, in your house. But they won't do any treatment. They'll just assess people, do they, and then refer them through an outpatient referral system.
Yeah, so our vehicle, because it's staffed with our mental health nurses, they're hooked into all our standard sort of clinical systems. So onward care can be brokered for people. I think that will be expanded nicely with the alliance we'll have between the vehicle and the Community Wellbeing Centre, because of course I always encourage people to think about our two distinct populations, which is people presenting at point of distress who have established mental health challenges, people who are presenting in distress because of life circumstances. and our onward referral at the moment is very much has been historically centred towards around people with mental health challenges, and what we've been doing is working really hard, distress brief interventions being case in point, to make sure that there is parity of response for those two populations.
And I think if I may, just to comment on the investment in navigators in mental health in the ED at 9 Miles is also good, because you're seeing again people, I assume, with specialist expertise who can navigate the systems, know the networks, know the options available to patients, and who needs to be seen quickly and maybe needs to be admitted and who doesn't. So I think you're to be commended for that as well. I don't know who's funding that. Are we funding that through the IJB, or who's funding that, or ED funding that? I'm not sure. I don't think it probably matters as long as it works well. So well done.
It's funded through the IJB, isn't it, Linda? So
yeah, well done, Dave. You found the money. The man with the money.
Wasn't me.
Wasn't me. Got to keep in with the finance people. I've got Annie and Ken waiting to come in. Annie.
Linda, do you think some of this innovative work is going to help us implement the suicide strategy? Because if somebody's in distress and they get a team of experts to go and support them rather than the police, or do you think that's going to hopefully have an impact?
Linda?
Thank you. I think the answer to that is hugely complex. We know that when we look at worldwide suicide trends, the single most important factor will be the state of the economy. And if we know there's been a downturn in the economy, it can take something like a decade to recover from the levels that were there beforehand. So I think we are going to have particular challenges over the next few years in terms of regaining the ground that we had made in terms of suicide rates, albeit that not as apparent with ourselves in Dundee in terms of elsewhere in the country. But absolutely, the sentiment has to be that we know that people are more motivated to tackle their problems if you catch them at the point of greatest need. And if you don't pounce on that, for want of a better description, then you're at risk of losing people again to the complexities of everyday life. So absolutely, my hope is that when you catch people at point of greatest need and you're assertive in your follow-up of that, you at least maximise the chances of doing the right thing by people. We know from a mental health side that effective treatment is hugely important in making sure that people don't take their own life, and in this case helping people build their problem-solving skills to mean that when impulsivity is there, one of the main intrapsychic driving factors for suicidality, that people have well thought through alternative plans for what they might do instead, rather than make an attempt on their life.
Ken.
Yeah, I think it's really good that we have these new and innovative services either up and running now or in the pipeline and about to be delivered. Just a quick question about the Navigator service, which I hear great things about. What's their coverage of the ED? Is it weekends, night time, or because obviously there's only 2 staff, so you wouldn't expect, it's obviously not a 7-day service. So what is actually provided? Thanks.
Ken, I'm not sitting in the exact timetable, but my understanding is we've always targeted night times and weekends.
Thank you.
Which is largely when violent crime with intoxication as part of that presents.
Okay, thank you for answering all our questions, Linda. Thank you for the report and all your responses today. I think we're very impressed by the work that's ongoing. And pass on our thanks to all the staff involved, and there's lots of innovation in here, and thank you to the finance team for finding the money to support you, and I hope things continue along these lines. Annie, did you want to come back in?
One last question. If we have this innovative work going on in Dundee, and I know this is Dundee IJB, Linda, are these conversations you're having with the other IJBs, so that if we've got good stuff going on, we can have it replicated?
Yeah, it's a good point.
Because I think that's one of the things the Minister's going to be looking for is our joined up approach.
Yeah, whole system's working. Linda?
Absolutely. So we meet under the auspices of something called the Integrated Leadership Group, which is our cross-Tayside sort of mental health group. So there's good cross-fertilisation there, and we encourage people to bring sort of projects for discussion to that. So certainly other areas sometimes have to deliver things in different ways because of rurality. For example, Perth and Kinross actually have ended up ahead of us with the NUC, which is sort of their version of a community wellbeing centre. They've sort of that in Perth City and are managing rural aspects of that, whereas Angus colleagues have taken a view it probably quite difficult for them to have a single CWC, and we'll look to other models, but the principles certainly are shared in order that we get equity of access for all Tayside citizens to the right treatment at the right time.
I think it would be good maybe when you've got more data on the mental health ambulance vehicle and how it works and what interventions and what's its impact on the overall service for patient perspective and from a service perspective. It maybe be good to share that with them as well, because I haven't heard that coming up at their IJB discussions. Not that I'm in them now, but we have said, Annie and I and Sam have made these statements at the board, and nobody's rushed over to say, but you all have your own networks. Is the integrated leadership group the same as the strategic? It's not the same as the SPL. Is that a strategic planning group? Is it? Because I noticed from Jackie Pepper's paper, she talks about an SPL or an SPG. Is that the same thing, Linda? Yeah.
No. So ILG much more our operations group. So it's
right.
the
strategic group, so and above that.
Absolutely. Yeah. And I agree in relation to the paramedic car. It's a good example of where rurality presents a significant challenge, because of course, if you have to send your single paramedic vehicle from one side of Perth and Kinross to the other, you won't see many in the course of a night. So they may well have models. It's remembering that our standard paramedics actually have training programs in mental health. One of the important things that the car does is support colleagues. So even if it's a standard ambulance that's sent to a call in Dundee or surrounding areas, if they want advice from the nurses and the specialist paramedics, they can simply be patched through for that.
Thank you, Linda. Raymond, did you have a last question you wanted to make?
Yeah, thanks very much. But I was really just in response to what some of Linda's responses. I mean, if we've got, I appreciate you have a joint up group that discusses the delivery of the care across the 3 health and social care partnerships, but is there a fear or an angst that there's different levels of care being delivered across Tayside? Because what we're looking at is an equity of care should be delivered for all people in Tayside. So therefore, what you're describing is that we're at different levels and people have access to care potentially at different levels. Is there a fear of that?
Raymond, I don't think there is. I think that because of the kind of unique geography of Tayside, people are really kind of well versed and well cited on the idea that having equity doesn't mean it needs to be the same. So that you can achieve the same outcomes for people in different ways. And the paramedic one, and I am taking liberties with this, but I'm just using it as an example, that you will have many more standard paramedic cars than a single paramedic response vehicle, which can work within a city boundary. And it might therefore be that you can absolutely see the value in a specialist mental health assessment being available to people who are presenting mental health challenges, but you might choose to deliver that way. You might spend your resource on upskilling all staff as opposed to having a small group of really select staff. You can achieve the outcome for people, it just looks slightly different.
Okay, thank you for that, Linda. So we are asked to note the report I don't think we're asked to make any decisions on it, but they and that the IJB delegate authority to the Chief Officer to sign off the final action plan. So are we happy to do that? Yep, okay, duly noted. Arlene?
Item 11, Integration Joint Board Budget Update. You're asked to agree the recommendation.
Okay, is this you, Dave? Are you on here?
Yes, Pat, thanks for that. And the kind of budget report itself is still a kind of bit of a moving feast. So you'll have noted that the Scottish Government's budget was kind of passed yesterday. So there's kind of maybe some further kind of changes around that compared to what I've kind of put in the report itself. I suppose the biggest one around that is the implications of an extra £100 million being provided to local government, which I note from the Finance Secretary has been around kind of pay for kind of non-teaching staff pay. So, you know, it's obviously kind of very fresh. So we don't know yet exactly what that'll mean, but as you would expect, we'll be kind of pushing for whatever that means to be kind of funding. An element of that funding would come through to the IJB as well for whatever that sort of kind of pay award settlement then becomes in 23-24. Still on pay, we kind of noted in the report the same, they were taking the same approach as NHS Tayside in terms of planning around a kind of 2% uplift on pay, but obviously there's a kind of pay award that's been offered on that, which is significantly kind of higher as well. So again, we need to kind of get the implications of that. The government has always said that pay within the NHS side of things will be fully funded. So again, we'd be expecting that while it would change the shape of our budget, that there'd be kind of funding coming in to cover that as well. So so like a couple of changes from in terms of the update on that. I mean, I did kind of say in the report anyway that kind of a lot of these figures are subject to change right up until probably we're setting the budget on the 29th of March. Dundee City Council has its budget meeting tomorrow afternoon. So again, we'll kind of wait to see what's the kind of implications on that side of things. Excuse me, and that will have. And we'll kind of factor in any implications into our budget. We do have two more, or kind of one more definitely in the diary in terms of development session for the IJB on the 8th. And Ken had kind of asked for a further one, kind of maybe the week after. So we'll get that one in the diary should we need it. So so everything else, I mean, the budget continues to develop. We'll keep you updated through the development sessions. But this is kind of the sort of formal kind of position as it is now put to you as a board.
Okay, thank you, Dave, for that. Have we got any questions on the budget? Everybody had a chance to digest paper. I always find it more difficult. I have to always read finance papers more than once. Any questions on that? Any questions on funding, overspends, reserves? Any of the things that we've committed to, the risk sharing agreement, the recharge to the Dundee IJB. So it looks like I'm not sure, is that an underspend or an overspend on out of hours, or is that lead partner services? That's Angus. So what is that, Dave?
Sorry, Pat. I think you've moved on to the next paper, which is the financial monitoring one. I got
carried away there with my. Yeah, so before we move on, if there are no questions, right, and I don't see anybody's hand up, so it's just an update, and we note the content of the report, we note the financial risks associated with COVID, and that they continue to monitor expenditure throughout the financial year. So I take it everybody's happy to know that. Okay, so let's move on to the next paper, Arlene.
Item 12, Financial Monitoring Position as at December 2022. This is for noting.
Thank you. Okay, do you want to just take us through that? Yeah.
Yeah, I'll just pass on to Christine for that one. So.
Yeah, thank you. I'll try and be fairly quick with this one. It's again our standard report that we bring to every meeting. So this is based on our financial position as at the end of December. So that's 9 months or 3 quarters into the year, and a projection for the final quarter based on the information that we're aware of at that particular time. Overall, we continue to project quite a significant underspend for this year. So an operational underspend of 2.87 million is projected at that point in time. Without tempting fate, the information that's come through in the last couple of months, or through January and what we've seen through February, hasn't significantly changing that. So we will bring our February position to the IJB in April, but obviously by that point in time we will be into the end of the year-end operational process. So we will have a better idea, and then the final year-end figures will be brought to the IJB in June when we bring our draft annual accounts as well. As normal, the detailed breakdown of the delegated services and where the sort of various overspends and underspends are situated are shown in appendices 1 and 2. There's probably just 2 key points that I just want to highlight to members today. 4.5.7 confirms the mechanism of the Scottish Government process that in terms of returning the unutilised COVID-19 allocation back to Scottish Government. So that's in line with our expectations. So it's just a highlight to not update members on that one. And section 4.6, we've added a final column into that particular table for the reserves, just to highlight to IJB members where we are thinking that the indicative reserves position will be at the end of this financial year. We've already alluded through previous reports that we're expecting a lot of our reserves to be significantly utilised during this financial year. A lot of it because of actual spend that's happening, for example, the COVID spend or the return of COVID funding, but other parts of it where we've mentioned previously things like Primary Care Improvement Fund, Mental Health Action 15, ADP funding, where Scottish Government have instructed us to utilise our reserves balances first before they then give us additional cash or additional allocations to meet the in-year spend. So we're expecting a lot of these positions to be virtually nil reserves to carry forward into the next financial year. So obviously that causes a bit of sort of financial challenges going forward, but it does indicate a significant reduction in our reserves balance for this financial year. And it's just that table's now been added just to illustrate the implications of it. The increase in terms of the general reserve balance is reflective of our projected operational underspend that we're expecting from this year, which will then slot into that particular line. But obviously that table will be developed as we go forward, and then we'll give you sort of final positions when we get towards the year-end position as well. So it was just to highlight that in terms of the actual quantifying the numbers as we're looking at. And obviously, if there's any questions or any comments, happy to pick up on these with you.
Thank you, Christine. Thank you for that. Any comments or questions from colleagues? No. I have a few, just one question really, and it's on Appendix 3, which I was jumping into before, which shows, I think, £1,000 overspend. Our share of it looks just to be under 400,000. Is that right, Dave, on out of our services?
Yeah, it's £1 million overspending out of hours hosted by Angus. Yeah.
Right. So is there a bit of a backdrop behind that?
Yeah, I mean, there's a number of things in terms of that out of hours kind of side, including the kind of the pressures on the system anyway. I think we've had a historical kind of overspend there kind of for a number of years, just in terms of a mismatch between the budget available and the service provided. But yeah, that whole impact on a kind of number of areas. I mean, COVID's hit as well. What we've been told by our colleagues in Angus is that the £1 million this year, they're kind of looking to try and kind of obviously reduce that on a planned basis for 2023-24, but it's not going to eradicate it completely. It'll maybe take a couple of £100,000 out of it. Now, what we're agreeing kind of locally through the CFOs is a mechanism then for us to kind of in effect try and manage those positions, because you'll see within that appendix that there's a number of areas that are overspent, but a number of other areas that are underspent.
Right,
And similarly, in terms of the hosting services that Dundee has, there's a number of kind of underspend areas that so we in effect kind of share that responsibility with our kind of Tayside colleagues. So we are looking at what we can do to almost like kind of balance these up across the piece. So while it might be £1 million or 800,000 or whatever the figure is for out of hours, that we'll then kind of shift around so we can try and manage that a bit better. So while services work to kind of manage down their kind of shortfalls.
The other thing is that the speech therapy is 41,000 underspent. I assume that's just lack of being able to provide defined speech therapists. I don't know the reason behind that. You don't need to tell me right now, but it might be useful if Christine came back to me. And then there's quite a few underspends on the lead partner services, prison health, the public dental service, which I'm surprised at, but maybe these are all COVID related. So they would have, people would not have been present at the public dental service during COVID. And possibly the same with podiatry, I don't know, but when you talk to people on care of the elderly services or diabetes services or anything to do with the frail elderly, there's always a huge demand for podiatry, which so you wouldn't, I don't know if these are all pandemic related, possibly, but maybe Christine could drop us a note and just with that.
Yeah.
I'll
speak to our colleagues in Angus and Perth and Kinross to get a better understanding. I suspect, like in a lot of our services, it'll be recruitment and retention, it'll be vacancies across a lot of it. I suspect that'll be the case, but I can get some clarity on that and come back.
Yeah, because in the podiatry, they can use podiatry assistants, but I don't know if they can work unsupervised or it's only in big clinics where there's podiatrists there. And I know GP out of hours is overspent a lot of places because of cost of locum GPs. So I'll leave that with Christine, if that's okay, Dave.
Yeah, I mean, just on that in terms of podiatry, I mean, I've been advised by Perth and Kinross colleagues that there are kind of plans in place to kind of change that position from an underspend to kind of utilise the budget within the service. So that'll be a feature of 23-24. So we'll keep an eye on that as it progresses.
They've got that lovely big place at the roundabout. They provide their podiatry in there. It used to be entirely a public dental service, but now it's got podiatry chairs in it, and they do. I can't remember what that big roundabout is as you drive into Perth.
Broxton.
Thank you, Broxton. I know they. So it's got nice facilities and a nice place to work. So hopefully they can do that. So we're just asked to note the content of the report, the projected financial position, the financial risks, and that you'll continue to monitor it and advise the IJB accordingly. Is everybody happy with that? Okay, the Arlene, paper 13.
Yep, so that's the attendances, the meeting attendances for 2022, and it's just for information.
Okay, my apologies, I wasn't at the, did we have a January meeting? No, we didn't have a January meeting. I'm just trying to think. I've lost track of all the meetings. I take it this is factually correct. Everybody's happy with what's against their name. If you're not happy, please let Arlene know. The meeting of the meeting of the IJB attendances we've dealt with. Just before we go on to the date of the next meeting, I take it that Invergowrie medical practice paper will come to the next meeting of the IJB. Is that right, Dave?
Sorry, my hand was not for that one in particular. I was just not something to do with attendances, but I'm not. I don't know if Diane and Vicky are aware of where we go with Invergowrie if it's next one.
Right. I actually thought I saw David Shaw popping up on the screen, but he's maybe had to go again. So yeah, my understanding is that we're working collectively with Perth and Kinross, because the issue about Invergowrie is that it was a GP practice from Dundee that actually provided the input into the practice, but it sits within Perth and Kinross boundaries. So to some extent, the strategic issues in terms of integration sit with Perth and Kinross, but we recognise that while the majority of their patients are from the Carsgowrie area, etc., there are some Dundee patients which also go to that surgery as well. So we're working collectively across the piece, Pat. To some extent, I think we would need to clarify this because it isn't a Dundee practice, albeit it has that link. It's actually a Perth and Ross practice. So we need to just agree how that best report. But our intention is to do that as collectively as possible.
Okay, thank you for that. If there are no other, sorry, Dave, did you want to something on the attendances?
Yeah, sorry, I was just back to item 13. It's in relation to the vacant service user representative position that's been vacant now for just about a year. In fact, it's a year now since there. So just to let the board know that we do have somebody who is very interested in taking up that particular role. I have kind of spoken to her. We've had a meeting, kind of gone through and explained what the IJB's kind of does and what her role would be in that, and I don't seem to put her off anyway. So we should hopefully get that kind of officially kind of ratified. I'm suggesting then in terms of the board that we kind of take it to the so we'll put it as an item on the budget meeting in terms of, you know, getting the board to kind of approve the appointment of that particular member, and that gives us an important kind of position filled on the board.
Right, that's great. Well done. That's good to have a service user representative. We look forward to meeting her. Well done for encouraging her, not putting her off, Dave. Okay, if there are no other business, I want to thank you all for your participation and input today, and I think we had a very fruitful meeting with lots of positive and work ongoing within the IJB, and also lots of planned work of things that we're taking forward as we move on. So I want to thank all the officers who provided papers, who came along and spoke today. We wouldn't be able to understand all of this without your help and support. And suffice to say, the next meeting is the 29th of March, and that this will be, Dave will be centre stage, as this will be the budget meeting. So we'll need to get our thinking caps on for that, Dave, and want to say thank you to everybody and have a good day.
Thank you.
Thank you. Bye.